Thank you all for being here. I'm LaVarn Burton, President and CEO of the American Kidney Fund. We are happy to be hosting this congressional briefing on the crisis in kidney disease. We are indeed in a crisis. Between 2009 and 2019, the number of people with kidney failure, also known as end-stage renal disease, or ESRD, increased by 41%. And that trajectory is predicted to continue over the next 10 years. In 2009, there were 574,000 people with kidney failure. And that number increased to more than 800,000 by 2019. If this trend continues, there will be over 1 million people with ESRD by 2030. We're here today to shine a light on this urgent issue, to raise awareness about the tremendous burden and the seriousness of kidney disease, and to talk about the steps we must take now to begin to solve the crisis in kidney disease. Kidney disease, one of the top 10 causes of death in the United States, is the fastest growing non-contagious disease in the country. There are 37 million Americans living with it and millions more who are at risk. There are a number of underserved communities that are the hardest hit by kidney disease, including Black Americans, who make up 13% of the US population, but account for 35% of Americans with kidney failure. Black Americans are nearly 4 times more likely than white Americans to develop kidney failure. And those who live in rural areas. 22% of dialysis patients live in rural areas compared to 19% of the general population. And those dialysis patients who live in rural areas more than 100 miles away from a dialysis center have a higher mortality rate than those who live closer. People from underserved communities also face barriers to receiving a transplant. For example, Hispanic and Latino Americans are significantly less likely than non-Hispanic white people to receive a kidney transplant. We're hosting this briefing not only to tell you about the current state of kidney disease, but also as a call to action. Research shows that people across race and socioeconomic status are equally likely to be diagnosed with kidney disease. But people of color are more likely to go into kidney failure, requiring dialysis or a transplant to survive. But with the right interventions and resources accessible to anyone with kidney disease, it's possible to delay or stop the progression of kidney disease. In today's briefing, we will explain the issues and provide steps forward to reduce the number of people who are facing ESRD. We will also be answering your questions, so feel free to submit questions or comments through the Facebook live video stream or the chat box to your right, and we'll try to answer as many as possible. We're so proud that Representative Lisa Blunt Rochester of Delaware is joining us to talk about how her bipartisan bill, the Care for All Kidneys Act, that would address a number of the current issues. Dr. Dora Hughes, Chief Medical Officer at the Center for Medicare and Medicaid Innovation at the Centers for Medicare and Medicaid Services, will also talk about the steps the Biden administration is taking to address health disparities. We will hear from AKF Patient Ambassador, Dr. Patrick G., the founder of I Advocate, Inc., about his experiences as a Black American with kidney disease. Mike Spiegler, AKF's Vice President of Patient Support and Education, will discuss some key results from a 2022 survey of 300 primary care and nephrology doctors. The survey showed some concerning trends regarding the testing for kidney disease and late referrals and offers some possible policy solutions. Before we go further, I want to thank the American Kidney Fund's 2022 corporate members for their support in making today's briefing possible. I hope you will find this briefing informative and I hope you walk away knowing some of the steps we need to take as a nation to address kidney disease in the United States. Our first speaker is Dr. Dora Hughes, the Chief Medical Officer of the Center for Medicare and Medicaid Innovation at CMS. Dr. Hughes previously served as an Associate Research Professor of Health Policy and Management at George Washington University, where her work focused on the intersection of clinical and community health, health equity, healthcare quality, and workforce. She also served as a counselor for science and public health at the U.S. Department of Health and Human Services in the Obama administration, helping to implement the Affordable Care Act. Today, she will talk about the steps the Biden administration is taking to address health disparities. Dora, you have the floor.
Thank you. Thank you so much. And I just want to express my appreciation for the invitation to participate in this briefing today. I'm going to talk a little bit about advancing equity through the CMS Innovation Center, as well as pulling in some of the work that our sister agencies are also doing in this space. If you go to the next slide, in terms of, I'm not able to see this, there we are. So just a couple of slides, I think, with CEO Burton's opening remarks. We can move through this pretty quickly. But again, I think some of the key stats here is that 1 in 7 adults have chronic kidney disease and 90% are unaware until their disease is advanced. So certainly that stat, as well as other stats, really provide marching orders for us on the federal level in terms of thinking about our role in addressing these issues. If you move to the next slide, also, we are quite focused as a broader equity agenda here at CMS, as well as part of the administration, on racial and ethnic and socio-demographic disparities. We know that chronic kidney disease is in many cases, unfortunately, a poster child for disparities. As mentioned, African Americans are 4 times more likely to have end-stage renal disease. Hispanics or Latinos are 30% more likely to develop kidney disease. But concerningly, we also know, not even in addition to developing the disease, many minority populations are less likely to receive pre-dialysis care from a nephrologist or be treated with home dialysis. And they are more likely to wait longer for transplants. And the majority of living donor transplants went to white recipients, 64% compared to only 11% for Black recipients and 16% for Hispanic or Latino recipients. If you move to the next slide, well, for those that are less familiar with the CMS Innovation Center, we were created in 2010 as part of the Affordable Care Act. We were charged with supporting innovative payment and service delivery models that could improve quality and reduce costs for our beneficiaries. We have a whole range of models, which is how we refer to our large demonstration projects that focus on the range of conditions, such as, in this case, end-stage renal disease, but also diabetes and heart disease. We focus on specific care episodes, for example, if you had to be hospitalized for a knee replacement. We focus on the range of provider groups. And also, we try to focus our models across different areas, different populations, such as rural populations. If you move to the next slide, as you see here, since our inception, we have sponsored more than 50 such models. Given time constraints, I won't dwell on any of these models, but currently we are operating 28 such models, some of which, again, focus on end-stage renal disease itself or related conditions. If you move to the next slide, we feel at the CMS Innovation Center that we have an impressive range of impact. In one 2-year study, we look to see how many providers are participating in our model projects and how many beneficiaries, how many individuals with Medicare or Medicaid, how many such individuals are being touched by our models. And we found that in a 2-year period, more than 900,000 providers or provider types are participating in our models, and more than 26 million beneficiaries across all 50 states. And so with our extensive range of impact, that does provide us the opportunity to really try to improve healthcare and health outcomes for the beneficiaries that we serve. If you move to the next slide, At the end of our first 10 years in 2020, it made sense to take a step back and think about what have we learned and what are we going to do for the next 10 years? What is our vision statements going to be? And as you see here, our vision statement is a health system that achieves equitable outcomes. Note that we emphasize equity right up front in our equity statement through high quality, affordable, person-centered care. I won't go through all of these different pillars, but again, I just want to emphasize our second pillar, again, is focusing on equity. How are we advancing equity through our models? How are we thinking through equity in terms of those that are participating in our models, the data that we're collecting, and the evaluation. So at the end of the models period, we know what impact we've had on the health and healthcare for the range of populations, the beneficiaries that we serve. If you move to the next slide, I want to touch briefly on a few models that I think would be of interest to you and have relevance to our discussion today with our focus on end-stage renal disease and disparities. If you move to the next slide, I think it's very important that although we are focusing on kidney disease, of course, we are also looking upstream, like what are some of the early steps that we can take to either delay the onset, slow the progression, or prevent entirely end-stage renal disease. And so one such model, the Diabetes Prevention Program, this model is the foundation for this model was many, many years of NIH investment and research expertise to find that exercise, diet, other healthy lifestyle changes can reduce significantly delay the onset of diabetes. NIH worked with CDC to translate the research into viable programs that could be adopted in many communities across the nation. And then we worked with CDC and NIH to think about how can Medicare, how can we reimburse for this program? We know that in many cases the providers are not traditional providers in the doctors or nurses sense, but these community providers in many cases have such a critical role. And so that's an example of, again, how across the different agencies, NIH, CDC, and now CMS, we're working together, in this case, to prevent diabetes, which we know is a major contributor to the development of kidney disease. If you move to the next slide, I also think it's important, again, even as we're trying to prevent the disease, to the earlier step that many Americans have chronic kidney disease and don't even know it. If you actually go back to the last slide, we also think it's important that we're investing in primary care so that as individuals go for their annual visit, their regular appointments, if they are trending, if it looks like they're developing kidney disease or a disease such as diabetes or hypertension that will increase the risk for end-stage renal disease, we're able to catch it early. So we have over the years, over our first 10 years and even now, invested heavily in primary care, thinking about what are some of the tools and the supports, the coordination, the patient navigators, the data, all of that, which we think can really, again, help to identify those who have early onset, those that are at risk, and can take the steps to intervene at a time when it's most likely to be effective. If you move to the next slide, and apologies, I'm zipping through, but I want to make sure we have time for the full panel. Another model, again, acknowledging that as much as we want to improve clinical care in the care setting, we know that there's so many other factors that contribute to the onset of disease and also influence the likelihood of the success of treatment. And so in this one model, Accountable Health Communities model, it was one of our earliest models that tried to build bridges between clinical care and social care so that providers were screening their patients to see if they had any social needs, referring them to community-based organizations and other social service organizations to see if they could have these needs met. And some of these social determinants of health or social needs might include transportation. Do they need help getting to their doctor's office? It could include problems with utilities. It could include food insecurity. Were they able to maintain a proper diet? All of these different social needs were critically important, again, to both prevention as well as proper care for those that are affected. But if you move to the next slide, we acknowledge with all of our focus on prevention, primary care, addressing social needs, at the end of the day, 1 in 7 Americans do have end-stage renal disease. And so how are we improving their care? One of our earliest models, Comprehensive End-Stage Renal Disease Care Model, or the CEC, began even, I don't want to say way back, but in 2015, 7 years ago. And that really was focusing on how can we develop accountable care organizations, or ACOs, that again will incentivize the whole range of providers, primary care providers, nephrologists, labs, and imaging, the whole range of providers and service providers to come together to provide integrated and well-coordinated care, particularly for patients with complex conditions such as those with end-stage renal disease. And we were able to show some improvements in healthcare utilization and quality measures and lower spending. We have rolled the lessons from that model into a more current model, the Kidney Care Choices model that just started this year. And part of the goals of this newer model is that can we achieve later and better starts on dialysis, planned starts on dialysis, not emergent, because we know that that will have an effect on how effectively such patients will fare and how well their health outcomes will be. Can we improve in better coordination of care? Can we have a higher number of individuals that are receiving kidney transplants and able to stay off dialysis for longer? And some of that we know we have to address the payment incentives for all the different providers to incentivize them to work together. And if you move to the next slide, in addition to that model, we also have a model that's focusing on end-stage renal disease treatment choices. And that one, we understand that our current model of caring for individuals with end-stage renal disease, in some cases, as a disincentive for those that may want to get dialysis at home. If we're paying nephrologists and other providers more for in-center dialysis, then we understand the results where very few patients, all things relative, are able to get dialysis in the home settings, which are often preferred settings. And so we also, in addition to home dialysis, we want to think about how can we affect this long wait list for transplants? How can we address the disparities in the living donor transplants? These are all such critically important issues that we wanted to go ahead and address on a parallel, but obviously sometimes these tracks intersect at the same time as we were thinking about ACOs and coordinated care. So we're very excited about our portfolio. We are very much working across other sister agencies to learn from them and to bring the various research and applied policy initiatives together in our work at the CMS Innovation Center. We also recognize it's critically important to partner with so many of you on the outside who have the real world on the ground expertise that can offer the patient, the beneficiary voice, can really play a meaningful role in shaping the work of the CMS Innovation Center as we move forward. So again, I thank you. I appreciate being able to participate in the briefing and looking forward to your questions at the end. Thank you very much.
Thank you so much, Dora, for taking the time to join us for this important briefing. We're now going to hear from my AKF colleague, Mike Spiegler. Mike has served as Vice President of Patient Support and Education for the American Kidney Fund since July 2015. He oversees a spectrum of program and services, including award-winning health education resources for patients and healthcare professionals, as well as our direct financial assistance that enables kidney patients to access life-saving medical care, including dialysis and transplantation. Mike is going to talk with us about some key results from a 2022 survey of 300 primary care and nephrology doctors. The survey showed some concerning trends on kidney disease testing and late referrals, and he'll discuss some potential policy solutions. Mike?
Well, thanks, LaVarn, and I appreciate the time today to talk about this important project. So this survey that I'll be talking about today is part of a groundbreaking project here at AKF called the Unknown Causes of Kidney Disease Project. It was a project started we looked at the 71,000 plus patients that we assist every year with direct financial assistance, as LaVarn mentioned. And we noticed a disturbing trend that we had 14% of those patients did not know what caused their kidney disease at all. They didn't have a definitive diagnosis as to what caused it. And we looked at those patients even further. We noticed they had a higher chance of losing a kidney transplant than those that did know the cause. That was concerning because if you look at the USRDS data where it's 5%, it seemed there may be a discrepancy happening with these patients who are in that situation. You can go back to the previous slide, please. So through this process, we wanted to better understand the perspective of healthcare professionals and what their CKD identification, diagnosis, and referral practices look like. We were really looking for things around like genetic testing and counseling too, but we were actually able to find some really, unfortunately, disturbing things, as LaVarn mentioned, as part of this process. The survey that we had was with 300 healthcare professionals. So you can see it was a very representative sample. It was very heavy on primary care, but we also had nephrology, transplant surgeons, NPs, and PAs, although most of those were in that primary care setting as well. They were rural and urban, a good mix of those, as you would expect. It was mostly adult patients. CKD is not very prevalent in pediatric patients, fortunately. And even as far as like practice settings go, it was a really good mix of health systems. So we felt like there was a really good representative sample of these 300 healthcare professionals. And we'd done a qualitative survey in advance of this, leading up to that, to really start to help really hone in on the right questions to ask. Next slide. So I mentioned that 5% of ESKD patients of cases of unknown cause, right? I mean, diabetes and high blood pressure are the main causes of kidney failure. But there's still that 5% that the United States Renal Data System indicates is kidney disease from an unknown cause. So we asked these doctors to, think about your patient pool, and these are patients, these are doctors with a pretty big CKD patient pool they were dealing with. What does your pool look like? So that dark blue that you see on these bar graphs are percentages of patients where they absolutely know the cause. That teal color is, I think I know, but it hasn't really been, absolutely verified by genetic test or biopsy or wherever it may be. So that happens with a lot of things, I think, in the medical field. But the striking thing, and really what we found kind of mirrored the data that we already had in our database, is that across the board, we had 15% in that little lime green piece at the top, all indicating I have no idea what caused my patient's kidney failure. So that was a big concern for us and kind of validated what we were seeing in our own data and speaks to the work that we need to do as part of this Unknown Causes of Kidney Disease project. Go to the next slide, please. So once a patient is identified as having CKD, you can see that while there's a significant number of patients who are diagnosed more frequently by a nephrologist, I think, as you would probably imagine, it's often important that if the cause is not clearly obvious, that a patient is being referred to a nephrologist. If a family history is there or genetic cause is suspected, it's important that it's doing it, but we're not really seeing that. And both in our qualitative phases where we interviewed primary care doctors and nephrologists, we were getting the same kind of thing that, if a primary care doctor is seeing this patient and they're not sure or it's a complicated case, that's when they're passing it on. So it's causing some of these patients to get really late referrals, even if they have a genetic or rare disease as well. Next slide. So we talked a little bit about, who is doing the diagnosis, but now moving really toward what the tests that they use are. And I know that this is quite a busy slide, especially on a smaller screen, but let me just give you the key takeaways here, is that blood tests, which are complete metabolic panels, that's the typical test you get when you go to your doctor for your annual physical, are happening quite frequently, common across the board. But unfortunately, there are other main tests for kidney disease. In fact, the one that most often is likely to find kidney disease in the earliest stages is a urine test. And that's really not happening very often. I always explain, if you're not familiar with the urine test, for kidney disease, I always explain to patients, if you're out there watching, it's kind of like, think of like a pasta strainer, right? When the pasta strainer works right, the water goes through and the pasta stays in. But when your kidneys filters aren't working as well as they should, some of that pasta, in this case protein, spills into your urine. So you can start to see some functional issues with your kidneys very early on. So, in absence of that test, it's really hard to find some of the earliest stages of kidney disease. And while we found that research is showing it's going pretty well with diabetic patients, which again, that's the number one cause of kidney failure, even in patients with high blood pressure, which is the second leading cause of kidney failure, it's not happening at the rate that we think it should. And there's been a lot of work in organizations trying to push to try to get that approach to get more urine tests moving forward. And I will tell you, when we did the qualitative phases of these interviews, and we did interviews with primary care docs, I mean, all of them were saying, yeah, I don't really test for urine, so I probably have patients in stage 1 and stage 2, but I'm just not checking it. And on the flip side, the nephrologists were telling us, I usually get patients in stage 4, maybe sometimes later, and they're never coming in with a urine test in hand. So I think looking at policy issues around that is an important part of how we can move things forward and better increase early identification of kidney disease. So if you then look at, you can go to the next slide. So this really just shows the discrepancies between a blood metabolic panel, again, kind of a common test during routine physicals, and a urine test. I just really wanted to drive home the point of the previous slide that there's a clear discrepancy between that EGFR test, again, that blood test, and that urine test. You can see the blood test first, the urine test second. Really, those should be pretty close to each other in most patients, but it's just not happening in a lot of patients. And while I didn't include information on genetic testing on this slide, we did ask questions about that as well, and found some pretty interesting things as well for maybe a future talk. I can talk to you about that as well. All right, next slide, please. So on this slide, I really wanted to call your eyes to the what is on your right-hand side of the bar graph. So on this slide, you can see when patients are being referred to a nephrologist, and knowing that most of the NPs and PAs that we looked at in this study were in primary care. So this is really primary care for the most part. The dark green on the left is stage 1 of CKD, darker teal, stage 2, lighter teal, stage 3A, beige is 3B, gray is 4, and so on. But what that translates to is that in the primary care doctors that we surveyed, nearly half of those patients aren't being referred to nephrology until stage 4 or stage 5. So if you think about all the new treatments and innovations that are now available for patients with diabetic kidney disease and rare diseases, it's really tragic to think about them that they're not being referred to treatment until so late, when maybe some things really can't be done to stop that final progression into kidney failure and needing dialysis and a transplant. So there's definitely some work to be done there. Next slide, please. And just pretty quickly on this slide, you can see that the referral time isn't that long once it's actually made for about half of patients. But for the other half, they're waiting sometimes 2 months or more, 3 months to see a nephrologist. And what we found when you break this data down even further, and again, through the qualitative interviews we did with patients, is that patients in rural areas are struggling. There's not a lot of nephrologists there, so the wait times can be bigger because the patient loads are just so intense. Next slide, please. So here is just some proof to what I was just talking about, and that finding that specialists available being a hurdle is definitely an issue. But following behind that is various confusion about what the next step should be, especially with complicated cases. Again, we had nephrologists that were telling us, I only get the super complicated cases. Everything else is staying with PCPs until it's very late. So one of the things we're going to be doing here as part of this project as well later this year, we've already started the early work on this, is some continuing education for both primary care doctors and nephrologists about when to refer, who to refer as we move forward. And I'll have a resource at the end of this as well. Again, I know there's a lot of data on these slides, but this project and all of this information, it's kidneyfund.org/UCKD. That'll come up on the screen in just in a minute as well, but I just wanted to plug that a second time. Next slide. So at our first summit, when we kicked this project off, we had over 100 different participating organizations, pretty much every rare disease advocacy group, all of our peers in the space, ASN, AKP, NKF, all available here, several different federal bodies, including CMS, that attended as well, and of course, patients. And as we went through and we thought about what would really help patients from a policy standpoint to get a definitive diagnosis, the group really came up with 3 that they suggested and put forward in our white paper, which is available on that website, which will come up again in a minute. The first was just making both eGFR and a urine test standard for annual physicals. I mean, that might not be the case for everyone, but it certainly needs to be in a much greater group than where it is now. And you can kind of see where some of that agreement is from the healthcare professionals that we surveyed. But also a referral required to nephrology when a patient enters stage 3 was something that was maybe proposed. Admittedly, this will probably be extremely difficult to do with some of the referral issues that we've seen below and a shortage of nephrologists that I just talked about and mentioned, but it definitely is an issue there. Or even as we're thinking about some of these rare causes too, could there be an ICD-10 code or something to simplify the genetic panels for nephrology? There's been some work done to simplify some of the blood and urine test panels for nephrology, but doing the same for some of these genetic tests is something that we put forward too, based on those that participated in that December 2020 summit. Next slide. So then finally, when you further break down these policy suggestions down by specialty, again, you can see that there's consensus across the board, especially in regards to making both eGFR and urine tests for kidney disease standard of care with annual physicals. And I think it's something that, again, there is definitely some work being done right now and some petitions to the U.S. Preventative Task Force on this as well, something that we certainly support here also as we move forward. Next slide. And finally, I mentioned the website earlier, but if you want to learn more about the Unknown Causes of Kidney Disease project, if you want to see a couple of the kickoff events that we had last year, we had one for healthcare professionals. We had one aimed at patients actually as part of Kidney Action Week last year. All of the information is there. It's all free. Our roadmap that we put together, our white paper for this, has all been put together and available there. So I appreciate it. And if we have time in the end, happy to take any questions. Back to you, LeVar.
Thank you so much, Mike. Our next speaker is Congresswoman Lisa Blunt Rochester, a member of the House of Representatives from Delaware. Representative Blunt Rochester serves on the House Energy and Commerce Committee and is a voice in Congress for reducing the cost of health care and prescription drugs for middle-class families, addressing the disparities in outcomes for communities of color, and tackling our nation's opioid and addiction epidemics. She worked closely with AKF on the Care for All Kidneys Act, which addresses the crisis in kidney disease and which she will talk about today. Congresswoman, I'll turn it over to you.
Thank you so much, LeVar, for that introduction. And good afternoon, everyone. And a special thank you to the American Kidney Fund for giving me the opportunity to address you all today. It's also great to see Dr. Dora Hughes from CMS and AKF Ambassador Patrick G. here to discuss a disease that's impacting Americans across the nation. Over 37 million Americans are living with kidney disease, and most of them don't know it because there are no symptoms in the early stages. That's a frightening statistic. And there are many more people at risk for developing this disease, especially in our communities of color. Black Americans make up 13% of our country's population, but 35% of Americans with kidney failure. Hispanic Americans are 1.6 times more likely than non-Hispanics to develop kidney failure. And Native Americans are 1.2 times more likely than white Americans to develop kidney failure. The prevention of kidney disease is the best option, but as these harrowing numbers suggest, far too many have already developed kidney failure. Kidney transplantation is a life-saving and life-changing option, as you all know, that can help patients get their lives back. Currently, 447 Delawareans are awaiting a transplant, and my district is exceptionally good at helping these patients get the help they need. The nonprofit organ procurement organization coordinating organ and tissue donation in Delaware has ranked #1 in the nation for the 14th year in a row. But despite the challenges of the COVID-19 pandemic, they have continued their stellar organ and tissue donation services, partnering with all of Delaware's 13 hospitals. A key partnership. It's clear that far too many people are impacted by kidney disease and kidney failure. We need to better understand the social, environmental, and occupational factors that contribute to the health disparities communities of color face. And that's why Congress must come together to fund research, prevention, testing, and treatment of kidney disease. It's our duty to help those individuals and their families that are affected by it, especially in minority communities. And that's why I was proud to introduce the Care for All Kidneys Act back last year. And CARE stands for coordination, accountability, research, and equity. The Care for All Kidneys Act would create a national strategy to understand the health disparities that have contributed to the disproportionate impact of kidney disease and kidney failure on communities of color. Specifically, this bill would diversify participants in clinical trials and include minority participants. It would develop access to home dialysis, increase access to dialysis in underserved areas, and address low kidney transplantation rates. It would also bring key stakeholders to the table, like the National Institutes of Health and the Centers for Disease Control and Prevention, so that we can hear from them on how to better care for folks living with this disease. Really, the Care for All Kidneys Act aims to do just that, be comprehensive, provide comprehensive care for those individuals disproportionately impacted by kidney disease, and reduce barriers among diverse communities so that all Americans have access to life-saving transplants. We all know that kidney disease can be prevented. It's up to all of us to put the infrastructure in place to do just that. And I want you all to know that my staff and I will continue to encourage other members to co-sponsor this important legislation, because we know that we have no more time to wait, and that in it together, we can make a difference. Thank you again for allowing me to speak, and I look forward to working with you on this important issue.
Thank you so much, Congresswoman Blunt Rochester, and thank you for all the work that you've done on behalf of people who are dealing with kidney disease. Our final speaker for the afternoon is Dr. Patrick G., an AKF patient ambassador and kidney transplant recipient. He is the founder of I Advocate, Inc., a nonprofit faith-based health and wellness organization. As an advocate for those living with chronic kidney disease and the conditions that contribute to this disease, such as diabetes and hypertension, Dr. G uses his personal experiences to teach, coach, mentor, and educate others on how best to manage their outcomes. He also ensures that underserved, undervalued, and disenfranchised communities of color have a voice in their quality of life and equitable healthcare access. Dr. G's mantra is, I am the voice for the voiceless and the face of the faceless in the fight against kidney disease. Patrick, I'll turn it over to you.
When I think about my journey, I think about the 4 different types of racism that I had to endure. They were institutional racism, which dealt with the policy and practices that reinforce racial standards within certain workplaces and organizations. The interpersonal racism, which are racial acts and microaggressions that are carried out from one person to another. Structural racism, which we see currently in our healthcare system, and also internalized racism. And those are the subtle and overt messages that reinforce negative belief and self-hatred within individuals. I know in April of 2013, when I went to my endocrinologist, who for the past 10 years had been dealing with my type 2 diabetes. And, you know, right at the end of my appointment, she told me that I was at stage 3B of chronic kidney disease, and I had between 35 to 30% kidney function. Now, nowhere in the 10 years prior to her telling me this news did I know that diabetes was the #1 leading cause of kidney disease. When I asked why I wasn't told earlier, she just assumed that I knew this, but all that I was told within that 10 years was to take these two forms of insulin, metformin, and to exercise. And that was it. Later, I was referred to a nephrologist, and within a couple of months, went to a kidney education class. My nephrologist at the time told me about two forms of modalities for dialysis, and that was peritoneal dialysis and in-center hemodialysis. And he made this statement to me. He told me that you're going to do peritoneal dialysis because you have a PhD and you're smart enough not to be non-compliant. So not only did he use a microaggression, but that was a slap in the face because I really didn't know that there was an educational requirement for doing peritoneal dialysis. So I ended up starting peritoneal dialysis in December of 2013. Nowhere in between that time was I ever told about a preemptive kidney transplant. And when I found out that I would have qualified and to have starved off going on dialysis, my nephrologist told me that no, it was best for people like me just to go ahead through the entire process of dialysis. So let's go to 2016 when I finally got on the kidney transplant wait list, and I was offered not one but two kidneys in March of 2016. They told me because of my girth at that time and the size of the kidneys, I would need two kidneys to be able to function as one. Little did I know that 30 minutes before the surgery, one kidney worked, the other one didn't, so they decided not to do the surgery. But I eventually found out that the reason that I was offered two kidneys was because I was actually the last person before the kidneys was going to be discarded. And in doing research, I also found out that this is a normal practice for people of color, that they know that they will offer them kidneys where they know they probably wouldn't function or they probably would reject within the first year. So I received my kidney transplant in April of 2017. And what was interesting, a couple of months after my transplant, I went to one of my transplant appointments, and my transplant surgeon told me that my kidney nephrologist, my dialysis nephrologist, had contacted him and asked him, why did you take my best patient? I lost my best patient because it was compliant, because instead of him seeing me as a patient, he actually saw me as profit. So from that moment, I had to go from being a patient to being a pupil and learning how to advocate for myself. There have been studies that suggest that some medical practices have been found to contribute to racial transplant inequities. As an example, especially when it comes to African Americans, they are disproportionately harmed by the delayed referral for kidney care and transplant evaluations. Even some studies have suggested that it may be due in part to clinicians' implicit and explicit biases, including physicians' misconceptions of the benefits of transplant for Black individuals, or the discordant and inaccurate beliefs regarding causes and prevalence of these particular disparities. So when you think about it, right now, it's less clear whether there are particular guidelines for clinical decision-making, including racializing kidney function estimates, could systemically bias physicians' transplant referrals and the evaluation process, thereby contributing to racial equities. So I have made it almost my life's work to try to help those to kind of navigate and be able to manage their conditions. But also, I would never want anybody to endure some of the racial biases and experiences that I have. And this is literally my ministry, and this is my calling to be able to do this. And I just really am looking forward to seeing the American Kidney Fund be the bridge to heal and mend these particular events, because right now nobody shows any empathy or any patience or any compassion for people of color, much less human beings, period. So I just really want to end on that note, and I'm looking forward to any questions that you may have. So thank you very much for allowing me to share.
Thank you so much, Patrick. And thanks to all of our amazing speakers. And thank you especially, Patrick, for your willingness to share your personal experiences so that we can all benefit from them. We will now open for questions, and if you can type your questions in the chat section, we will refer them to the appropriate panelists to give us some additional information. While we're waiting for that, I'll turn to a couple of questions that I have. Patrick, what can each of us do in this fight against kidney disease and kidney failure?
Just continue to do what you're doing. You are engaging with legislators, which is extremely important. You are sending health literacy to broken, poor, disproportionate communities and rural areas. Just continue to encourage those that have been negatively impacted by kidney disease to elevate their voices and not just speak for themselves, but speak for other people that can't speak for themselves.
Thank you so much. I'm looking to see if we have any additional questions from our audience. I don't see any, but let me turn to you, Dr. Hughes. And could you talk a little bit about what role diversity in the medical workforce may play in terms of outcomes, health outcomes for minority populations? And how does having a shared identity affect the doctor-patient relationship? And if you could comment also, particularly in your role at CMS, what can policymakers as well as educational institutions do about increasing the diversity in the medical workforce?
Thank you, and thank you for that important question. I think if you look through across a number of studies, they show that when there is racial or ethnic coordinates between the provider and the patient, that in many cases there is a better patient experience, there is improved communication between the patient and provider. In some cases, there's a better understanding of, depending on the condition, there's just more experience. And particularly you see that and for certain provider groups, for example, if a Black dermatologist would be one easy example. And so, but then also very importantly, you also see benefits in terms of access. Many minority physicians from certain racial and ethnic groups, they will go back and serve the communities from which they came, and that improves the just access for the patients significantly so in the areas. And so across, whether it's access or quality, you do see benefits when there is a racial and ethnic concordance, again, between patients and physicians. In terms of diversifying the clinical workforce, I would certainly give a shout out to my colleagues at the Health Resources and Service Administration. They certainly are, in my view, the federal lead on workforce and provider training, and they offer a number of pipeline programs, because as you well know, you can't create clinicians overnight, and so we really have to invest at the early stages in terms of what are some of the special medical or other professional programs that can start in the early years with exposure, and perhaps there's opportunities in high school, and certainly more immersive experiences in college. So even in later stages of education, that you are starting to grow the pipeline. And I also just think in more recent years, as we've heard about some issues that very much reflects upon what Patrick shared, but some of the more racial and ethnic clinical algorithms, for example, and how that may be contributing to the inequities that we're seeing. Some of the beliefs, I think the New England Journal ran a piece on the erroneous beliefs that certain groups hold about, in this case, African Americans with thicker skin, they can't feel pain. I mean, all of that, again, just shows that even as we're thinking about diversity in the workforce, we also have to make sure we're educating the workforce very generally, those that are already treating patients, so that we are contributing to high quality care across all of our different patient populations.
Thank you so much, Dr. Hughes. And Mike, can you talk about what patients and public policy stakeholders can do to improve the information that's available for primary care physicians so that they can better communicate with their patients regarding kidney disease?
Thanks, LeVarn. I mean, I think an important part is really that shared decision making and being able to be armed with the things that you need to say. When you hear something, I mean, a prime example, I'm the caregiver for my mom who has stage 3 of kidney disease. I went to an appointment with her. The doctor was going through all of her results and basically just said, your kidney function's off a little bit, nothing to worry about, and just was going to move on. And I stopped and said, well, actually, I have some questions about that. It's really knowing kind of what those key things are that you're hearing and knowing the questions to ask. And it's why our Know Your Kidneys campaign, which I'm sure my team will put up into the chat on the kidneyfund.org website, is a great resource. There are questions guides there if you are already diagnosed with early stages of kidney disease, if you're at risk, if you have diabetes or high blood pressure. There are really questions to ask. It's really about being an advocate for yourself, knowing what questions to ask, and really forcing that shared decision making, because you have a role in your health or your loved ones' care.
Thank you so much, Mike. And let's go back to Patrick. You talked about your own experiences with kidney disease and then transplantation, and the fact that certain information was not given to you as you progressed along this continuum. In terms of the patients that you're working with through your advocacy network, are you seeing any changes? Do patients generally have, let's say, more information than you have? What can we do, both as a nonprofit organization and just all of us in our various roles, to try to increase the information that's available to patients in a timely fashion?
Well, when you look at the impact, as an example, of COVID-19 and with health clinics closing down, and it hurt the access of information to be delivered for diabetes, kidney disease, heart disease, obesity, things like that. Myself and an overwhelming number of advocates have just steered patients, those that have access to broadband, to be able to go to the kidneyfund.org website, where they can actually go to the information portal and get this research. Now, in the rural areas, for those folks that don't have information, I would download the information and personally take it to them, and also leave enough copies for them to be able to distribute into their communities. So I just think that if we continue to just pour into broken communities, and when you look at the social determinants of health, these things are still very prevalent today. There are some communities that are living in food deserts, while others are living in food apartheid, when folks want to eat healthy, but they can't because there's more fast food restaurants than grocery stores. And then when you deal with transportation issues and environmental issues, it can certainly continue to be a lot of barriers, but just making the information available and accessible is a great step to just getting this information out throughout this nation.
Thank you so much, Patrick. I think we have time for one more question. I'm going to turn back to Dr. Hughes. Dr. Hughes, could you talk some about what the Biden administration is doing with regard to all of the inequities and disparities that we've talked about today?
Yes, thank you for that question. I would say that I want to say maybe 4 weeks ago, our administrator, Chiquita Brooks-LaSure, released a framework, the CMS framework, and priorities across all of the centers at CMS for addressing inequities. And you'll see that some of the issues, some of the steps forward, we are would hold true across all the centers. For example, how can we collect more socio-demographic data? There's certain core issues. For example, end-stage renal disease certainly would be one that we would be working with our colleagues in the Medicare Center, our colleagues in Medicaid, in terms of what are some of the issues that we all need to address. You mentioned workforce. That is an example of the issue that we are trying to reach out to our colleagues in HRSA as an example, or SAMHSA if it's behavioral health. So I say that we do have a framework. I would encourage everyone to look on the CMS website that provides more information. We're working across the centers on core issues. We're reaching outside of our lane for issues for which certainly there's just more expertise than some of our sister agencies. But across all of these, we want to be able to demonstrate measurable improvements. We want to be very concrete, very specific. So this time next year, when we are having the summit, we'll be able to report back on some of the improvements that we've made in access and quality of care. And I would say for all of this, even though we're certainly focused on CMS and our sister agencies today, this, as you pointed out yourself, is a Biden administration top priority, and it's been very encouraging also to see us moving in lockstep with our other colleagues in different sectors, whether that's education or labor and others. And so I think that at the end of this administration, certainly will be able to show positive improvement in a number of respects.
Okay. Thank you so much, Dora, and thanks to all of our speakers today. Thanks to all of you for joining us, as well as our sponsors who've made this program possible. This concludes our 2022 Congressional Briefing on the crisis in kidney disease. We hope that you have gained some insights today and that you've been inspired to take action not only for your own health, but for our communities as well. Our next session on CKD stage 3 and high blood pressure will begin right now. So be sure to join us for this session as well as the rest of the week.